So welcome everybody to this third part of the ACNS Peripheral Nerve webinar. Today we have two speakers. Dr. Fatma Al Zahmi will be talking about electrodiagnostic studies in peripheral nerve surgery, and Dr. Khizer Rana will be talking about the role of imaging, ultrasound and MRI in the diagnostic work of peripheral nerve surgery. We have three chairs today: Prof. Debora, Garozzo, Prof. Indira, Bagavathula and Prof. Heinen. So without much ado, we'll start. I'll hand it over to Prof. Debora. Prof. Debora?
Yes. So hello again. This is our third appointment for this course about peripheral nerve surgery that is organized under the umbrella of the ACNS. Once again, I would like to express my gratitude to Professor Yoko Kato, who is not with us today, but it's thanks to her enlightened vision that we have been able to establish the Committee for Peripheral Nerve Surgery in the ACNS, and that we have also been able to promote this online educational course. Then, of course, I also have to include in my thanks Professor Raja and Professor Boone, because without their immense work, we would not be able to set up this program. And then it is my pleasure to mention that the speakers that we are going to have today are working with me. So this is my team basically. So I largely rely on Dr. Fatma for electrodiagnostic test, and Dr. Rana unfortunately carries the burden of all the imaging for peripheral nerve surgery that we do here. I just would like to express my gratitude for their daily work, because without their work, I wouldn't have been able to treat the patients. We have been working together for 5 years, and I think we have immensely benefit from collaboration. And it's important to highlight how electrodiagnostic studies and imaging are part of the diagnostic assessment for peripheral nerve surgery, and both have to be integrated. So we have online as chair also my dear friend from Germany, Christian Heinen, who's also been a supporter of the fact that imaging is essentially to be integrated in the assessment, in the diagnostic workup of issues related to peripheral nerves. And so then I will let him comment afterwards. But right now, I think it's time that we give the word to Dr. Fatma, and she will introduce her to the mysteries of electrodiagnostic studies.
Thank you, Deborah. I can share my screen now, yes. And you can see my presentation or my slides.
Yes.
Okay. So thank you all, and thank you, Deborah, and the organizers for letting me be part of this course. And Fatma Al Zahmi, neurologist. I specialize in peripheral neuropathies or neuromuscular disorders. Peripheral neuropathies are a big part of it. So we're going to talk about electrodiagnostic testing and the role in peripheral nerve disorders. The goal is not to make you an expert in doing or reading electrodiagnostic testing, but when you look at the report of a nerve study, you're able to see what are the different things that we're evaluating. I think also to understand the limitation of the electrodiagnostic testing, looking at the test, I hope you'll be able to tell if this is an adequate study. Can you rely on it, or is there parts that are missing? Do I need to repeat it? Do I need to use another modality such as imaging if you have high suspicion and doesn't go with your clinical suspicion? So yeah, well, at the end it will be like, what do I need to look at or how do I evaluate this is a good study or not? So using the electrodiagnostic testing, from our standpoint, I should be able to tell Is there a neuropathy, a focal neuropathy or not? Well, is it is there a problem? Is the problem is focal, multifocal? Is it diffuse? Is it a reticulopathy, double crush? Is there an underlying like diabetic neuropathy with superimposed ulnar neuropathy, for example? Sometimes hard to differentiate if there is an underlying systemic issue. I should be able to tell you the mechanism of the neuropathy. Is this a demyelinating condition? Most of the compressive neuropathies are demyelinating, which is a good prognosis, or is there an axonal injury or axonal loss? And when there's an axonal loss, it's already severe. How severe? And that can help you decide about the management. So if I have carpal tunnel with just slowing of the conduction across the wrist, likely it's mild or mild moderate, and conservative management is enough. Once I see evidence of axonal loss, then I would probably, the patient would need surgery. I should be able to tell you the time course. Well, acutely in the first 3 to 4 weeks, the nerve test and the EMG might be completely normal. When I see abnormalities, should be able to tell you, is it subacute, late subacute, early subacute, is it chronic? Prognostication, yes, it can help. It's not perfect, obviously, but demyelinating conditions are most likely to have a full recovery. Axonal loss, if it's severe, then a higher chance of incomplete recovery. And sometimes we do the electrodiagnostic as part of the follow-up to see the nerve recovery. Again, I emphasize what Dr. Debora has already said, that you don't just rely on one modality. So sometimes the electrodiagnostic, I need to use other modalities such as imaging. It also is extension to your clinical examination. So what is my clinical impression? My physical examination tells me, and this can prove it or disprove it, or recognize if there's another condition, other mimics, like is it a C8 radiculopathy or is it an ulnar neuropathy? A normal study does not rule out that there is a neuropathy. Do recognize that there is technical errors are very, well, not uncommon or common, but yes, experience is very important. And so technical errors in doing the study, interpretation errors are also a problem. Be aware of the mimics. It is okay if you are, doubting, or if the report does not mention that, yes, this is ulnar neuropathy, not C8, it's okay to call and discuss with the neurophysiologist. Did you rule out this condition? Is it plexopathy? How do I know it's not plexopathy? Wouldn't be nice if you operate and the patient doesn't improve. So electrodiagnostic is wide range of testing. For the sake of this talk, we're going to focus on the nerve conduction testing and electromyography. Yeah, in the nerve conduction, we look at sensory and motor and delayed responses. I'm not going to go through them today, and then the needle EMG. So the nerve conduction, we check the motor response of the nerve, the sensory response, and the late responses. For a motor study, so you put the stimulator where the nerve is, we have here our landmarks or the course of the nerve. So in this picture, you see the stimulator at the ulnar nerve and the recording as at the ABB. And what do I look when I interpret the study? So I give the stimulus, and this is the motor response that is measured from the muscle. So I look at the latency, which is the time from giving the stimulus until I see the CMAP, the compound motor action potential. So for the median nerve should be less than 4.5 milliseconds. So if there is prolonged latency, then I am thinking that there is something that's slowing the nerve. So prolonged latency will go along with slowing of the conduction velocity. And this is a demyelinating condition. I look at the amplitude of the motor response. So in a demyelinating condition, I'm not losing axons, so the amplitude should be normal. If the amplitude is reduced, then I'm thinking that there is an axonal loss. And the conduction velocity, just to show you how to calculate it, but you don't need to know that. So just again, the stimulus, the initiation of the motor response, I look at the latency, I look at the amplitude, and then you stimulate at 2 different points and get the conduction velocity. This will be, as I might go through some things fast, and you'll have a handout at the end, so you'll be able to read through the slides that I'm skipping. Yeah, let's go. The sensory responses are a smaller amplitude, so are measured by microvolts, and that's why they are more sensitive to electric noise in the room. So if I'm doing the nerve test in the ICU, for example, if the patient has swelling, then it's more likely to have technical artifacts. If the temperature of the limb is cold, we have to make sure it's 31, 32 degrees Celsius. If it's cold, it will affect the sensory response more than the motor, but motor also. And the same thing, I look at the latency. How long does it take to initiate the sensory response? I look at the amplitude, not so much conduction velocity. We don't do distal proximal stimulation here. So looking at the responses of different nerves, I can tell what is this, is the pathophysiology, the underlying pathology, is it an axonal loss? And in that case, we will see, where is it? Okay, so this is a nerve, completely normal. I get a nice CMAP. This is normal. I lose 25% of the axons. The amplitude of the motor response is reduced, completely gone. So in axonal loss, the conduction part, I will see reduced the amplitude of the CMAP. In the EMG, you'll see signs of denervation. I will talk about it later. In the demyelinating conditions, compressive neuropathy is mostly demyelinating unless very severe or chronic, and that will give me slowing. So the latency, it will take longer to initiate the response, and the velocity, conduction velocity will be slower across that part where there is a compression or a demyelination. I thought I'd give you a nice example. This is a patient who had a demyelinating condition. So latency was supposed to be less than 4.5 milliseconds, which in the peak of her illness, the latency to initiate the median nerve motor response was 16 milliseconds, very much prolonged. The amplitude was not was normal. Conduction velocity very slow, should be more than 49. 2 years later, when the patient is recovered, look at the latency with a normal velocity improved. So this is an example of a demyelinating condition without axonal loss. And the demyelinating conditions have a higher chance of having a full recovery. Sometimes we do inching study, especially with ulnar nerves. So if I want to know at which segment of the nerve is the block or the demyelinating lesion is, you stimulate at 2 centimeter intervals and then see where is the drop happens. So to recap, so my demyelinating conditions are milder, better recovery. You see prolonged distal latency, slow in the conduction velocity. If I have conduction block, I'll see some drop in the amplitude of the CMAPs. Axonal injuries, it's more of reduce the amplitudes of the sensory and motor responses. The velocities and latencies should not be affected. Now we go to the second part. So usually the nerve conduction done by the technician, the EMG is done by the physician. So the needle is the recording electrode inserted into different muscles, and we measure the few things. So you look at the muscle at the resting state, and we look for the presence of spontaneous activity. If the muscle is normal, should not have any noise during rest, no spontaneous activity. And then you ask the patient to voluntarily activate the muscle slightly and then increase the activation. And when I activate the muscle, I'm looking at the, okay, we'll talk about it, the motor units and analyze the motor units. So here, if the muscle, the spontaneous activity, we refer to them as, or mostly we're focused on fibrillation potential, positive sharp waves, and they indicate a denervation. It's a subacute denervation and axonal loss. As I said, it takes 3 to 4 weeks to generate these. So if you see them, it's not acute. We are early subacute at least. I see that sometimes when the patient is not able to relax, there's always a muscle contraction. A good neurophysiologist should be able to differentiate between these are motor units because the patient is not able to relax versus true spontaneous activity, because that's kind of, it affects the interpretation and then probably the management. Myokymia is a nice finding. We get excited when we see it, and that's you get a referral from Dr. Debora for is this post-radiation plexitis is very not pathognomonic. You see it in other conditions, but classically in post-radiation plexitis or radiculitis. So that's the spontaneous activities. I focused on fibrillation potential and positive sharp waves. I wouldn't bother you with myotonia and neuromyotonia. Then you ask the patient to activate, and now I look at the motor units. Again, I look at the amplitude of the motor unit, I look at the phases and the duration. And then I ask the patient to activate more and see how much recruitment pattern is he able to fully recruit or partial. You'll see this in the handout. I'm not going to go through this for the sake of time. There are a few cases I'd like to talk about to demonstrate how important a good electrodiagnostic. Also, please know that there are limitations. I know you think neurologists are perfect, but we're not. And every study has its limitation, should not be interpreted alone. Timing, very, very important. So you get a patient admitted for shoulder dislocation, admitted yesterday, and now he has a wrist drop, and everybody wants, do nerve study today. No, it's going to be normal. So it's too early. So in the first 2 to 3 weeks, you might not see anything. You might do a study at 2 weeks, and it's completely normal. Do repeat the study. The temperature, sometimes people don't pay attention, but especially in people who are diabetic or for some reason neuropathy, they might have cold extremities that may make their responses even worse than what they are. Measurement errors, sometimes when people do the measurement across the elbow, if they overestimate, the velocity will look normal because they overestimated, and the opposite is true. Anatomic variations, be aware of like ventricular anastomosis. Sometimes the patient tolerance to the procedure. So if the patient could not tolerate the needle EMG, I should not say normal study. I should say the report should tell you that limited needle EMG because the patient was not able to do the study or complete the study, and these two muscles were normal, for example. So the conclusion should tell you that the study was not completed. And high operator dependence. So experience does make a big difference. Technical artifacts, technical issues, anatomic variation, timing. American Academy of Electromyography it does recommend that these electrodiagnostic testing are done by an experienced or somebody who is specially trained, and they should work closely with the peripheral nerve neurosurgeon. Common entrapment syndromes. I'm not going to go through many details, but I do want to demonstrate 2 cases. Carpal tunnel, everybody knows about it. Ulnar neuropathy at the elbow, so we prefer to use ulnar neuropathy at the elbow rather than cubital tunnel syndrome because, yes, cubital tunnel is the most common site of compression, but it can also happen at other sites. You get the tingling. So how do I diagnose ulnar neuropathy at the elbow? The conduction velocity should drop more than 10 meters per second across the elbow segment. So between the wrist and the forearm, it's, let's say, 50, and then drops by 10, so it's 40 across the elbow. That's abnormal. Or there is a drop 50% in the CMAP, the amplitude of the motor. I should always think about radiculopathy, and if indicated, rule it out. Let me give you this case that I had in the last few months. I think Dr. Khizer knows about it. So 40-some-year-old guy presents, he goes to the orthopedic, he has hand weakness for 5 to 6 weeks, and some pain at the wrist, but not really tingling, no sensory loss. He had, the hand did appear like a partial claw appearance, and he did have weakness of the finger abduction, so the FDI was weak. The extension is normal, wrist extension is normal, ADM was weak. So mainly thinking of ulnar neuropathy. So what do I see? So this is the motor response, and just highlight the important ones. So the ulnar motor response at the adductor digiti minimi is not too bad. It's 4.7, which is within normal. But when I compare to the right side, the normal side is almost 50%. So that's relatively abnormal. There's no slowing across the elbow. When you look at the FDI, it's more severely affected. Look at the amplitude, it's only 0.4. The right side is 9. Again, no slowing across the elbow. Sensory response is normal. So ulnar response at the digit 5, which is what we normally do, and at the dorsal ulnar cutaneous nerve, both are normal amplitude and latency. So already, going towards what you're thinking, which is the impression was ulnar neuropathy at the wrist. And then I do the needle EMG, and you see that the FDI is the one that is abnormal. Flexocarpi ulnaris is normal. Then, so as part of the a good study, so I have the C8 muscle abnormal. I explore other C8 innervated muscle. So the interpretation tells me sensory responses are normal. FDI is very abnormal with severe axonal loss. That I have so the fact that the duct is normal, the fact that motor response, severe axonal loss, tells me it goes with ulnar neuropathy at the wrist. And then I also in the report tell you that I did think about C8 radiculopathy, and I ruled it out, or at least there's no evidence to support that. So we asked for an ultrasound, the ulnar nerves imaged from the elbow all the way to the wrist. We say that we're suspecting a compression at the wrist. So they find that there is mild thickening of the nerve, there is slight subluxation at the epicondyle. So a little hypermobile nerve, mild thickening, but then I have severe axonal loss, and it doesn't explain the findings, that the fact that the DUC was normal. So then we look further, and guess what we find? That there is a mass that is compressing the ulnar nerve slightly distal to the Guyon's canal. So if you have a good, and from the radiological appearances, they suspected that it's a malignant. So the management now is different. The patient went to have a resection and biopsy of this mass. Luckily, it was a benign thing, but yeah, the management is completely different. So if your clinical suspicion, your electrodiagnosis tells you something, continue to investigate. So that little ulnar thickening and hypermobility at the elbow was not convincing to explain the degree of weakness and atrophy and axonal loss for the patient. So it's not very common to have ulnar neuropathy at the wrist. If it's the cyclist palsy, it goes, conservative management is enough. The fact that the dorsal ulnar cutaneous is preserved, and that's the hallmark, basically, that it's normal if the compression is done at the wrist and not the elbow. Do you want to talk about how much time do I have? Radial nerve. I'll also mention a case. So you can see this, the site of the compression, either at the spiral groove or at the posterior interosseous nerve at the arcade of Rose. Like this, the radial release surgery is controversial with suboptimal results. And every time I see a patient, suboptimal results. So this patient was actually sent from ED. Sorry, it's not from emergency. This patient was sent to Dr. Debora for a radial nerve release because he was studied at a different hospital. He's 53, has weakness of his left hand for 8 months. He does have wrist drop and finger extension weakness. The nerve testing at the other hospital was reported as a radial neuropathy at the spiral groove. He does have weakness of the wrist extension, but he also has weakness of the flexor carpi ulnaris, so that's an ulnar nerve muscle. The hand grip is right-handed, so the non-dominant hand would be weaker, but 24 compared to 46 is a big difference. This is the sensory responses, extensive sensory testing, normal, because we kept looking and looking, it didn't make sense. And then with the motor response, I just took the important ones. So at the EIP, and then always compare with the other side, looks borderline. So the EIP, radial innervated muscle, is abnormal. The FDI, ulnar innervated muscle, is abnormal. Then you do the needle EMG, and you find abnormalities in the triceps, find abnormality in the FDI, in the EIP. So the evidence of neurogenic changes, active denervation in the and these mentioned muscles, which are radial and ulnar innervated muscles. So we say, well, the fact that the triceps is abnormal, then the lesion, the abnormality, should be proximal to the spiral groove, because the triceps should be normal if it's spiral groove. The fact that the sensory responses were normal, usually if it's a compressive lesion, sensory responses are affected. And then you also have the ulnar innervated muscles being abnormal. So you say subacute to chronic pure motor, mononeuropathy of the radial nerve, mononeuropathy of the ulnar nerve. So you have two pure motor mononeuropathies together with normal sensory responses. Makes us suspect that multifocal motor neuropathy, a type of, you can say CIDP or inflammatory neuropathy. He gets an MRI of the forearm, and they do see increased signal or denervation changes in these muscles, so triceps and coneus, ED, accessory digitorum communis, minimi, so radial muscles above the spiral groove, ventral spiral groove, and flexor carpi ulnaris. So patient now is diagnosed with multifocal motor neuropathy and on IVIG. So with a good electrodiagnostic testing, you avoided unnecessary surgery. I do have another patient who had an radial release surgery, not by Debora, of course, somewhere else, a few years ago. He never improved, and he just let it go. And then now, this year, he had ulnar neuropathy in the other side, the opposite side. And that's when we diagnosed him. He had antibodies positive for MMN, and he's also an IVIG. So, yes. So, yes, radial neuropathy is, true compressive neuropathy, but it is not, always look for mimics, always look for red flags. I mentioned the red flags. Again, common foot drop, I'm not going to mention the red flags. So, if the pain is out of proportion to the clinical picture, as a compressive neuropathy should not be that painful. So if the pain is extreme, think about neuralgic amyotrophy. If the patient has systemic symptoms, think of vasculitis. If the patient has multiple nerves affected at different times, like, oh yeah, 2 years ago I had ulnar nerve. This year I had foot drop. The other year I had wrist drop. Then do think of mononeuritis multiplex, or, which is usually severe, but multifocal motor neuropathy. The interval between each nerve affected can be few years. Okay, last 2 slides, I promise. So, as a peripheral nerve surgeon, always be mindful that a false negative does not rule out the problem. Do look at the report and think about the quality of the report, the expertise of the people doing the study, reporting the study makes a big difference. Don't take one study as make your diagnosis based on one modality. You can use imaging and your clinical judgment, of course. Think about the mimics, make sure they're ruled out. And severity, over reliance on a single modality is not a good idea, obviously. When you look at the report, does it tell you if the neuropathy, is it focal, multifocal, is it diffuse polyneuropathy? Does it give you a localized, or it says that I cannot localize? Sometimes my report says non-localizable ulnar neuropathy. Is it demyelinating? Is it axonal? Am I able to tell you the severity, or I should mention the severity, the chronicity? So looking at these things, you should be able to say, is this an adequate study? Do I need to repeat it? Do I need to ask for more? So my references, thank you. And I'll send you a handout with the slides. And I'm not sure the questions to be done now or later, up to you, Debora.
We will do the questions at the end, also because we have a quiz, and the quiz also should include some questions from the previous webinars. Now, before we start talking about the imaging, I would like to ask my other chairs to comment, and I think if Dr. Indira Devi wants to say a few words about the importance of the electrodiagnostic tests in peripheral nerve surgery, we would be very grateful to hear her opinion. Indira?
Yeah, thank you. Thank you for this opportunity. I would like to tell very clearly one about the electrodiagnostic studies. If it is following an injury, you must be very clear about when you are asking for it. There's no point in asking for it immediately after the injury, because they can be neuropraxia, or it can be a more severe injury. And as we know that the neuropraxia can last anything between few days to maximum of 6 weeks, which is an extended neuropraxia. So we need to have a proper window. So from the clinical history and examination, it would be very clear whether what type of injury we are talking about, and then decide about the timing of the electrodiagnostic studies. This is number one. Whenever we are expecting a entrapment neuropathy, okay, if we can decide about the level of the entrapment, whether at the elbow or wrist or so on and so forth, across any of the likely levels of entrapment, we should ask for inching technique, that is proximal and distal to the so-called level of entrapment. And this is especially useful for cubital tunnel and carpal tunnel. And other third thing we have to remember is what we should do during surgery. During surgery, the importance of the electrodiagnostics is basically the nerve action potential, SNAP. This one, when we want to decide whether it is a neuroma in continuity or a neuroma. It's not really a neuroma in continuity, but it is neuroma in discontinuity. So we can do the nerve action potentials across the segment and then decide what to do with the concerned involved segment, whether to do end-to-end anastomosis, means define the proximal part of the nerve and distal part of the nerve, and then do a grafting across or primary repair or whatever, depending upon the defect, and then or do a end to side, so that when we are not very certain about the number of functioning fascicles across the neuroma in continuity, better to do side to end to side. Okay, so these are the important things I would think. Deborah, if you have some more, you can add.
Yes, thank you. So I think there are a couple of things that have been clearly highlighted by the speaker and also the chair. So Dr. Fatma said very clearly that EMG and nerve conduction study sometimes may not actually confirm the presence of an entrapment. This is something that we regularly see, as she said, in patients with early onset or also with mild symptoms. So something that should be kept in mind is that if you are really convinced that the clinical diagnosis is that of an entrapment, even if you do not have electrodiagnostic confirmation, you should keep your patients on follow-up and then maybe reassess them a few months later. So usually what we do is that I will follow up the patients clinically, and then maybe we repeat the investigations after 3 months, and we see if there is any change, or sometimes even after 6 months. Yet we can still have situations where the entrapment is not documented. And this is something that we typically see, at least in our experience, with thoracic outlet syndrome, patients who have symptoms related to purely irritative thoracic outlet syndrome, which means that there is no evidence of neurological deficits, have always electrodiagnostic studies which are unremarkable, unless sometimes we see that there might be also the association of another entrapment, because let's not forget that we might also have the so-called multiple crush syndromes, which are the associations of more than entrapment. It's not infrequent in clinical practice to see that you may have a patient who has a radiculopathy plus a carpal tunnel, or may have a thoracic outlet syndrome and a carpal tunnel, or a thoracic outlet syndrome and an ulnar neuropathy at the elbow. So this is something that has to be considered. So electrodiagnostic tests are definitely very helpful, but let's not forget that might give you false negatives at the beginning or in certain pathologies. For instance, when you have an ulnar neuropathy with hypermobility, we also have seen several cases of patients who had a negative EMG and nerve conduction study. And that brings us to the importance of imaging in peripheral nerve surgery, because right now the gold standard for diagnostic assessment in this pathology is both electrodiagnostic test and imaging. That can be ultrasound and in certain cases also MRI. So it's probably time that I just leave the word to Dr. Khizer Rana, who is the radiologist I, unfortunately for him, rely on for all the imaging investigations, and he's going to illustrate us the application of MRI and ultrasounds. Please, Dr. Khizer, if you want to take the word.
Thank you very much. Can you guys hear me?
Yes.
Good afternoon. And firstly, thank you for giving me this opportunity to share my thoughts with you guys. And very welcome to everyone who's joining us. So you guys can see my screen?
Yes, yes.
Excellent. Okay. So,
Yes.
right. So the purpose of this, so let the slide plays. Sorry, just bear with me. I'm having some technical issues here. Excellent. Okay. Right. So as clinicians, you guys are not expected to know the finer details of radiology, but it is absolutely essential that you know some basics. So the idea of this session is going to be to help the thought process in deciding the appropriate imaging modality. Then secondly, we're going to do some standard imaging techniques, as well as some specific techniques we utilize for conditions such as thoracic outlet syndrome or dynamic scanning in ulnar neuropathy. I will go a little bit over some normal appearances, and we'll do some cases and Q&A. So as with everything else, majority of the times for coming up to a diagnosis, we require multiple modalities. X-rays and CTs are not commonly utilized. Ultrasound and MRI is the one which we're going to be focusing on. But I'll go over a little bit because we still do utilize these from time to time. So X-rays are not routinely used, but they have their pros in terms of they're relatively inexpensive. Almost every radiology department will have it, and you can do multiple joints in one sitting, very well tolerated, and doesn't take that long to do. When it comes to neurosurgery and nerve compression syndromes, X-rays are still utilized in things such as looking at osseous pathology such as exostosis or compressive neuropathy. The cons for X-ray, it's a radiation exposure examination, and if you are doing it in a patient as a follow-up, then it does accumulate the radiation dose. There is usually a delay between acquisition and reporting. It does not allow real-time dynamic assessment and doesn't provide much information regarding soft tissue structures. CT is pretty much similar, it's just higher dose, but the bony resolution is excellent. Relatively more expensive, but again, dynamic assessment is not very easy and it's usually not possible. Ultrasound has come a very long way and is extremely useful when it comes to peripheral nerves. It is very easily accessible, very portable, and more is being utilized by clinicians as well in the outpatients. So if you get accustomed to using it, you could be providing, point of care assessment in a lot of cases. It can also assess in surgical site planning and as well as intraoperative, and also useful in nerve transactions in order to accurately identify the gaps between the retracted end. I would like to mention actually ultrasound is sometimes even better at looking at the peripheral nerves, particularly when it comes to smaller nerves. So you're looking at small digital nerves or things like that. MRI, in order to get that resolution, you have to either have a specific protocol, and it's not that easy even after that. Ultrasound also allows real-time dynamic assessment, and it is also utilized for for therapeutic use, such as ultrasound-guided interventions. The negative factors for ultrasound, the main thing is it's very extremely operator dependent. So there is no set protocol of scanning things, and what I might consider highly abnormal might not be considered as abnormality by another radiologist. So it takes a long learning curve, and it's limited in its assessment when it comes to superficial structures. It can only look at superficial structures. Deeper structures, it's difficult to evaluate with adequate accuracy. Limited field of view, but we can also scan multiple joints at the same time. So it does have that benefit. It's relatively cheap, very easily available almost everywhere. MRI is the other thing which we utilize most of the times in neurosurgery. It gives excellent bone as well as soft tissue assessment and highly sensitive. It can also detect other pathology which the other modalities do not. And it's a non-radiation scan. The cons being it's rather expensive, takes a long time to acquire. The report can take like days, so it's not an immediate assessment like an ultrasound. Right, so I'm going to talk a little bit about ultrasound and MRI in particular, and we will discuss some common pathologies that we require and scanning techniques. So ulnar nerve is one of the common ones that we do, but almost any nerve can be scanned. The superficial ones are better for the ultrasound, whereas MRI is better for the deeper ones. In terms of the equipment we utilized, and I would recommend that you utilize a high-end ultrasound machine for scanning of peripheral nerves. We have a G, but almost all of the companies offer sort of setups. The other thing which is I would like to mention, particularly for clinicians, is that now we've got portable ultrasound probes, even cordless ultrasound probes, to provide bedside assessment if needed. So if once you start using it, the more you use it, the more you'll be able to get comfortable with identifying the pathology. Right, so just a little bit about what the normal appearances are. So a normal peripheral nerve on ultrasound has a typical echogenic appearance, like a honeycomb in cross-sectional. On longitudinal imaging, you will see the nerve fibers being parallel. And here are some examples to demonstrate. So on here, we've got a normal-looking nerve, and you can see this hypoechoic band is the nerve in longitudinal section. You can see the nerve fibers are relatively parallel throughout. And the normal appearance on the transverse, this is the honeycomb echogenic appearance that I was mentioning. So this is what a normal nerve would look like. And there is possibility of confusing the nerve sometimes with a tendon, because tendon can have similar echogenic appearances, but the bundles and the fascicles are much thinner in the tendon. I'm going to talk a little bit about ulnar neuropathy, particularly because this involves dynamic assessment, which is important. The entrapment can be caused at the cubital tunnel, but it can also be affected at other sites. But cubital tunnel being most common, it can be extrinsic versus mechanical. This is the patient position. So you can position the patient across from you. Transducer is placed transversely over the medial epicondyle, and nerve is assessed for normal echogenicity. And while we are doing this, we ask the patient to flex their arm. This is to check for any nerve subluxation and dislocation. So this is an example of normal versus abnormal, so that you guys are able to appreciate. So if you see this on the left-hand side, you will see the nerve fibers are nice and parallel in longitudinal. When we look at the TS, you got the nice honeycomb appearance with echogenic fascicles. And similar cross-sectional area through an abnormal nerve shows you a much more hypoechoic, swollen nerve, which has lost its definition, and the fascicles we cannot identify. Similarly, if you see that in longitudinal, you will see that the nerve, compared to the other one, is much thicker. It's not as echogenic, and it's much darker as compared to the other one. Hypermobility of ulnar nerve is something we assess very regularly. We have devised a grading system in terms of if the nerve is hypermobile and to what degree is it hypermobile. So on the this will play. So you can see, I don't know if the video is going to play, but yeah. So you can see the nerve. This is the hypoechoic structure. When the patient flexes their elbow, it jumps over the medial epicondyle anteriorly. So this particular patient had bilateral snapping ulnar nerves. And if you can also appreciate the hypoechoic appearance and thickening of the nerve on both sides. So this is ulnar neuropathy with background hypermobility of the nerve bilaterally. Ultrasound is extremely useful when it comes to post-operative patients who've got metal implants, because these patients a lot of times either may not be able to go into the MRI because of the metal. Also, even if they do get into it, there will be a lot of artifacts, so you do not see any details. So in those cases, ultrasound is extremely useful. So this particular patient had a metal fixation of the elbow. The ulnar nerve can be seen as these thickened hypoechoic structure right on top of what is a metallic screw head. So this patient was actually having impingement on top of that screw as the patient was moving the elbow, and the neuropathy was being caused secondary to that. So very important role for ultrasound in dynamic scanning, particularly in post-operative patients. This is an example of a post-traumatic neuroma. What you will see here is a more fusiform thickening of the nerve. And the nerve before and after looks relatively normal. In cross-sectional, you've still got a thickening and loss of normal echogenicity, and that honeycomb fibrillar pattern is gone. So ultrasound is an excellent modality, but is very operator dependent. It's relatively quick, relatively cheap, and should be utilized in outpatient settings if you are comfortable with doing. Okay, so I'm going to move on to MRI, and we'll go through some imaging protocols that we utilize, some special imaging protocols that we utilize for things like thoracic outlet, and also discuss a little bit whether we should be using contrast routinely or what are the circumstances where the contrast should be utilized. Okay. So this is a slide which just outlines the basic sequences which are utilized. So the T1 weighted sequence is very good if you're looking for nerve fascicles and fine anatomical detail. This is a fat-based sequence. So anything which has got fat between it will show the outline and details very good. So for anatomical detail, T1 weighted sequences should be assessed. The fat suppressed T2 weighted sequences are more fluid based. They're therefore better for edema and inflammation in neuropathy cases. And then you've got the proton density sequences, which are a mix of the two. So they give you a best of both worlds, but they're not as good as one or the other when it comes to the finer details. The additional sequences which we utilize sometimes are 3D imaging, motion reduction, diffusion weighted images, tensor imaging, muscle specific sequences, and vascular suppression sequences. And also post contrast T1 rigs. So these can be utilized in things like when you're looking for abnormal neural enhancement or tumors. So this is just a quick side to side for normal versus abnormal findings of the nerve. So a normal nerve will show signal intensity almost isotense to the muscle. So when you're looking at a nerve on a T1 weighted sequences, it should be similar to the signal of the muscle. Whereas T2 imaging, it can be slightly higher or sometimes slightly bright. You can see the fascicular pattern on both T1 and T2 in a normal nerve. And enhancement is usually not present unless there is a pathology. So if you see significant enhancement in a peripheral nerve, it usually signifies an abnormality because it's a disruption of the barrier. Okay, so just going over regarding T1. So key facts: perineural and intramural fact is assessed. It is very useful for anatomical detail. T2 and fat suppressed sequences is good for any muscle changes, any muscle edema. So on here you can see this is a oblique coronal stir. So this coronal stir is a fat suppressed sequences. Depends on the machine which you're utilizing. The fat suppressed sequences can be either a PDFS or a stir or a spare, but the principle behind them is all the same. So the appearances of the nerves is going to be the same regardless of which one you're using. As long as it's the fat suppressed sequences, you will see the nerve as slightly bright. Abnormalities will be picked up within the muscles as edema. So muscle denervation changes can be picked up and can be picked up as early as 2 weeks. These are very nice sequences, and I think Dr. Debora and generally the clinicians really love them because they put things in a bit more anatomical perspective. So these are called MIPS and 3D sequences, and we can subtract out the signal from the nerves to give a nice continuation and 3D images, which can look at brachial plexus, lumbar plexus, or any peripheral nerve. Post-contrast imaging, as I mentioned, we sometimes utilize. So this is an example of abnormal versus the normal on the left-hand side. So you can see the normal nerves of the lumbar plexus in this case, the sciatic nerve in this case, nice and thin, parallel, and no significant enhancement. Whereas you can see bright signal throughout in these thickened sciatic nerve fascicles on the right-hand side. Okay. So, an example of acute neuropathy. What would acute neuropathy do? Now, I was listening to Dr. Fatma and Dr. Debora. The early changes, even on the EMG, take up to 2 to 3 weeks. So MRI is able to pick up on those early changes as early as 15 days following the initial nerve injury. And what are you going to see? You're going to see denervation muscle edema, which can be very subtle. So this is the normal muscle, whereas you can see this high signal in the muscle in front, and you can compare it to the other side. So if you see an abnormality, generally speaking, there's always a normal other side to compare with, so that's useful. But the early muscle changes can be rather subtle. The pattern of muscle denervation generally involves the entire muscle which has been supplied by that particular nerve. This is in a very impressive looking slide in terms of the appearances is grossly abnormal, and this clump of grapes, this nodular appearance, is pathognomic of neurofibromatosis. We can see similar appearances in other chronic inflammatory diseases such as CIDP, but this is pathognomic of neurofibromatosis. So you will see these clumps and nodular swelling extensively throughout, involving all of the peripheral nerves. When we do get cases like these, majority of the time, either they will come up with one large lesion and several other small lesions, which some of them might not be clinically felt. In those instances, we do have a protocol to do a full body MRI, which looks something like this. So the idea of a full body MRI is we do fat suppressed and T1 whole body, and we pick out whatever lesions we can, including the large ones, which you can see here, as well as here on the right-hand side. But there are also multiple further tiny lesions which we would not otherwise pick up. And once we've got these, then we will do some dedicated smaller images through the largest lesion, which are of more interest. Another example of neurofibromatosis. So the image on the left-hand side, this is a fat suppressed. The reason why we know it's a fat suppressed is the subcutaneous fat is black. Similarly, the marrow which is rich in fat, is also dark. And you can see this very thickened abnormal distal sciatic and tibial nerve and a large schwannoma at the edge. Now, the same appearances on a T2 weighted sequences, and similarly post-contrast. Now, the post-contrast, you will notice that the proximal nerve itself is not actually enhancing, whereas this larger lesion, which is separate to the main continuous lesion, is enhancing. Okay, a little bit about the thoracic outlet syndrome, because I want to mention the dynamic imaging techniques and the importance of the dynamic imaging technique. So the basic thoracic imaging protocol should include at least this. So if at your institution they're only doing limited number of sequences, this is the basic sequences which should be there. The optional would be a sagittal T2 of the cervical spine and contrast if needed. The important thing here is the abduction and abduction, so a dynamic scanning. And the reason being that a lot of times these patients will have a normal appearances when the arms are abducted, which you can see here. And as soon as you ask them, you take some pictures in arms abducted, you can appreciate the reduction of the costoclavicular distance quite significantly. This is the neurovascular bundle. This is the subclavian vein and the subclavian artery. So the vessels are being flattened out. The neurovascular bundle itself is being flattened out. And you can see how significant the reduction in the distances, from all the way from 18 to 5 millimeters. Generally speaking, if the reduction, so there is a normal reduction on the costoclavicular and the subpectoralis spaces when the arms are abducted. But if the distance is reduction is more than 50%, and the patient has got symptoms of thoracic outlet, then we consider as diagnostic. This is an example to show you of nerve injuries with root avulsion. Now, this particular patient had a flail limb, and we did an MRI with and without contrast. Now, was contrast useful in this case? Yes, because it confirmed the presence of pseudomeningeal. Was it necessary? Possibly not. You could have done without it as well. The other place MRI with contrast is quite useful is nerve sheath tumors, because it will show you the enhancement pattern. Now, the commonly encountered ones that we come across is neurofibromas versus schwannomas. And I get the question asked all the time, can you differentiate? Most of the time you can, based on the imaging. So if the smaller lesions can be slightly difficult to differentiate, but there are some features which you can look for. So for example, the schwannoma will be more eccentric, and it is usually more heterogeneous when it comes to contrast enhancement, whereas a neurofibroma does not have a particular capsule, and it causes more fusiform thickening of the nerve rather than eccentric thickening. But otherwise, in terms of the appearances, they can look sometimes similar, particularly when it's the smaller lesions. This is another patient. This is the same patient with the coronal sequences, the traumatic injury, left flail limb. The reason I put this in is because this is the post-contrast scan. So if we didn't have the information regarding that the patient has had a traumatic avulsion, then you've got a lesion which is high signal on T2, low signal on T1. So you could have a soft tissue lesion which can behave similar to that, but a soft tissue lesion would have enhanced. So in this particular case, I suppose the contrast was useful. So contrast is not essential, but in complicated cases, if there is a doubt, I always recommend that you should give contrast. Right, so just some final thoughts. Which investigation to do first line? Generally speaking, ultrasound and MRI for peripheral neuropathy. You just have to decide which one is more relevant. The choice would depend partly on the availability of the expertise and also sometimes patient availability, because some patients might not be able to have the MRI done. The clinicians and the radiologist need to speak to each other all the time. Dr. Debora is in my office almost every week. We discuss all the cases together. The information I get from her is so useful because then I can give her a better report, very relevant report. And sometimes the information which I'm looking for comes directly from her rather than the images themselves. So although you guys are not required to know the finer details of imaging, but just some basics hopefully would help you utilize the investigations better and also understand the limitations of the imaging. Thank you very much.
Thank you, Dr. Khizer. I think that was a quite comprehensive and informative lecture for everyone. Actually, I probably come to your office to discuss cases more than once a week. And I think that we should actually urge everybody to do that because it's extremely useful. Now, before we start considering the questions that we have received, if Christian Heinen is back online, because he had to go for an urgent evaluation, I would ask him to comment on the importance of integrating imaging and in particular ultrasound in the practice of nerve surgery.
So, dear all, thank you very much for having me and for setting this webinar up. And well, first of all, I want to congratulate the organization of this webinar, but also the unit that you created at your place, dear Debora. This is because things are so much better and so much easier if you have the proper persons to use the proper tools for the diagnostics of your patients. This changes the world of peripheral nerve surgery completely. So we are lucky enough to have a similar situation here. Plus, as you said, especially in ultrasound, I don't think that a nerve surgeon can go into the MR and do the examination yourself, but especially in ultrasound, this is basically made for us to use it ourselves too, because we see the structures all the time, we do the surgery all the time, we know the layers all the time, and so on. So I think there's absolutely no reason why not to use proper diagnostics and proper imaging, and especially there's no reason to not use ultrasound. As it was beautifully pointed out in the talk that we just heard, of course there are limitations, and there are situations that MR is the better choice, and there are situations that ultrasound is the better choice, and there are a lot of situations that to combine both is the best choice. So I don't think it should be an either-or question. It's always to find an individual solution to have the best diagnostic results, to then have a proper consultation and of course a proper surgery. In addition to what we saw, we also used the ultrasound intraop. So this is another use in difficult cases, in trauma cases, or in rare conditions, strange tumors that you don't know exactly the extent or what is evolving because of the quality of imaging is, for example, all the post-inflammatory torsions and constrictions. So you have, if it's only one fascicle involved, you will not find it just by seeing, palpating the nerve. You need ultrasound to properly detect the exact site of the lesion. So it's not just the pre and post-op assessment, but it's also an intra-op assessment. And of course, what we all would love to have, and this was also shown, especially with the MR imaging work on the muscles, is that we want to know, for example, after grafting a nerve or decompressing a nerve, will it recover? So this is, I guess, the main question and the main task for our imaging friends to create us a tool that maybe with a combination of imaging and electrodiagnostics, we will be able to predict more or less thoroughly if a nerve will recover or not, or if any other means need to be taken. So this would be my wish for the future, to have something like that. And for the rest, I could not agree more that this is mandatory to have it in your workup, especially with ultrasound being achieved and more or less available at any place. So all of the anesthesiologists who do vaginal blocks will have a proper probe to see the nerve. So this is not fancy stuff. This is something that you can do even with the old machines. It's not a problem. As long as you have 10 megahertz and a linear probe, you will be able to very much see a lot of pathologies within the nerve. So again, there's no reason to not use it.
Yeah. Yes, I absolutely agree. And what you said about the fact that this kind of equipment is actually available everywhere, it's cheap, it's effective, is also something that makes us emphasize the importance of global neurosurgery also for peripheral nerves, because differently from other subspecialties in neurosurgery, peripheral nerves, which are actually statistically more frequent than thought in low-income, middle-income countries, can be done because we don't need any. I mean, with the electrodiagnostic test and ultrasound, we can already set up a useful diagnostic workup. So thanks so much for your comments. Before the participants are starting to specifically ask questions to Dr. Fatma and Dr. Khizer, I see that a few of them have already typed some questions here, and I wanted to just reply to some of them. So Dr. Manikandam Pachayappan has asked, what is a double crush? This is something I mentioned at the beginning. So we give the definition of double crush or multiple crush syndrome when you have a clinical presentation that can be related to the presence of more than one entrapment, or there might be also a radiculopathy and distal entrapments. So as the examples I made before, you may have somebody who may have a radiculopathy, for instance, due to a bulging disc at C5 and C6, but then you find out that there are symptoms which might be consistent, for instance, with a carpal tunnel syndrome, or there might be, sometimes it happens in some patients, that there might be the radiculopathy and the ulnar nerve and the median nerve. There is a little bit of controversy because some authors assess that we should specifically call a double crush when it's the same nerve, which may get a compression on two different locations. But a lot of us actually use the terms double or multiple crush just to define the association of multiple entrapments, irregardless of which are the nerves which are involved. Then also Dr. Manikandam, that I think should probably have a better study of neurology, sorry to say that, asks how to differentiate between C8 radiculopathy from ulnar nerve and elbow. Now, there is something that you have to consider. In C8, because it's a compression on a root, that means that you are not going to have a specifically defined distribution distally, because C8 can actually give symptoms both in the median and the ulnar distribution. So this is something that you have to consider. When you have a compression of the ulnar nerve at the elbow, then all the symptoms, whether they are sensory or motor, specifically happen in the distribution only of the ulnar nerve. Then Dr. Manikandam also asked about the difference between neuroma in continuity and neuroma in discontinuity. Okay, so basically the neuroma in discontinuity is something that happens when you have a transection of the nerve. So there is a causative mechanism that has resulted in the transection of the nerve, and you are going to have two stumps. At the end of each stump, both the proximal and the distal stump, there is always the progressive formation of a swelling that is called neuroma. In a neuroma in continuity, the causative mechanism has not been able to transect the nerve, so the nerve apparently maintains its anatomical continuity because the connective layers appear to be intact. But there is a complete disruption of the internal architecture, which eventually causes the formation of scar and fibrosis, which results in an enlargement of the caliber of the nerve, in a change of its morphology. There is also an increase of the consistency of the nerve on palpation. So that segment of the nerve may have been irreversibly damaged, and that is responsible of the lack of function distally, but yet you still see a continuity of the nerve. And this is something that was that is specifically to be studied, for instance, with ultrasound and intraoperative tests, as Dr. Indira also mentioned, because then you need to understand whether the presence of the neuroma in continuity is associated with the lesion that can recover, so we can hope to have some spontaneous recovery, or the damage of the internal architecture has been so severe that we have to consider resecting the neuroma and then graft it to bridge the two stumps. Are there any questions, any comments for Dr. Fatma and for yeah, okay, so here there is a question for Dr. Fatma, because the nerve by Dr. Turnwell Kinalemang, because the nervation changes take 2-3 weeks to appear on EMG, and conduction block can mimic intact axons on early NCS. What specific red flags features push you toward immediate exploration rather than waiting for electrodiagnostic maturation? Fatma, would you comment on that, and then we surgeons might say a few more words?
I'm sorry, I got lost a little bit. What's the question again?
The nervation changes take 2-3 weeks to appear on EMG, and conduction block can mimic intact axons on early NCS. What specific red flags features push you towards immediate exploration rather than waiting for electrodiagnostic maturation? So you can say, what is the point of view that you have when you see?
So I'll leave the answer to you. Like, basically, my role is to give you the findings, and then the neurosurgeon is going to decide.
Yeah, okay, but the
neurologist... I think the time interval also, yeah. Okay.
Yeah, okay. So yes, exactly. Let's say that first of all, it depends on the kind of mechanism. Okay, so we also have to consider, for instance, if it's we have what kind of mechanism, if you have associated lesions, and if there is a complete sensory or motor denervation, or for instance, if there is some residual function in the distribution of the nerve which has been affected. So this is not a very easy question to answer, because it's actually complex, and we should probably consider more specific examples of cases when we have the symptoms, the clinical presentation, and decide if we have to go for exploration soon or if we have to go for conservative management. But for instance, those are the cases where certainly it would be helpful to integrate with imaging and see which are the results from the ultrasounds or the MRI. And then there is another question also given by Dr. Turnwell. So given the limitations of current electrodiagnostic modalities, particularly the delay before the nervation potentials are detectable, what is your perspective on emerging techniques such as diffusion tensor tractography, peripheral nerve elastography, serum neurofilament biomarkers? Do you foresee this becoming reliable early markers of axonal continuity in peripheral nerve trauma, potentially allowing same-day surgical decision-making? Okay, so regarding diffusion tensor tractography, which seems to be related to radiology, I think we should have Dr. Khizer offering his opinion on that.
So diffuser tensor elastography, this is not something which we commonly utilize. It is mainly being used at the moment in tertiary care center who only deal with these sort of things. And it is not a routine investigation because the specificity is still not that great. So it is a good research tool, and it might be being utilized at some of the larger tertiary care centers, but I have not utilized it in our day-to-day routine and don't see any use of it in the acute phase.
Okay, and regarding the other techniques that you mentioned, Dr. Turnwell, well, as you mentioned yourself, these are still experimental, so we don't have really that much evidence. They can give us safe information, and because normally when you go for surgery, and if you decide that you cut a neuroma, or if you decide that you do a graft reconstruction or a nerve transfer, this is a one-shot procedure, to say so. You really have to be sure that you are not jeopardizing the possibility of a spontaneous recovery, because we should probably remember also that usually when you have a spontaneous recovery, it does certainly better than our repair surgery. And then regarding the question given by Turnwell Kenalemang again, saying if ultrasound and MRI can show nerve continuity and fascicular disruption immediately, why are we still waiting weeks for EMG changes before deciding on nerve exploration? Should imaging be the new gold standard for early surgical decisions? Okay, so talking about nerve injuries, in the past, if it was considered that it was a close injury, we would have waited for the EMG and for clinical follow-up to understand whether there might be a possibility of spontaneous recovery, or we were supposed to go for surgery. But nowadays, with ultrasound, if we have a patient who has sustained a closed injury and the ultrasound or the MRI gave us evidence that there is a severe lesion, then yes, we actually go for earlier surgical exploration. Christian, I think you can also confirm that we have definitely changed the timings in nerve injuries since we have introduced imaging, right?
Absolutely. So, well, again, I think it's not a question of which one is the better one, or if we have a gold standard or silver standard or whatever standard. I think it's just to need to know that some methods have limitations, and if you use them in an appropriate way, you will always get a proper answer. So we know that electrodiagnostics are not there right from the start, because they have some delay because of the Valerian degeneration. So this is something that takes place, and we cannot. In some people, it's 3 weeks, and some people it's 4 weeks, and so on. So it's. But if you see a nerve cut with the ultrasound right away, so why wait? I completely agree. This has changed the way of thinking to have an early an early assessment and an early therapy of the nerves the same way around. If you see the nerve is not cut or is not completely bruised, then you will wait. So it's not that imaging is only pro surgery. It's just to know what the nerve is about. So it's not that if you have an ultrasound, you necessarily operate on all the nerves. Actually, it's the opposite because you can see it. And then, after 3 or 4 weeks, you have a reliable electrodiagnostics. So you have a qualitative assessment of the nerve and moreover of the muscle, which I think is even more important. So it's just to use the methods at their best timing, and you need to have in mind more or less what happens within a nerve that is denervating because of a trauma or a compression or whatever. So then you're able to use it in an appropriate way. So I don't think it's either or, it's always all together. And not to forget the clinics. Because
exactly.
we see patients that have horrible conduction studies. The nerve in ultrasound is a disaster and they have more or less normal function. So the clinics always beat everything. So this is something that you need to be very much aware of, that you have a proper clinical assessment, not like, I don't know how this is in your countries, but in a lot of traumatological reports of the ER, we see peripheral motor and sensory no deficits with the flail arm, broken leg, cut off hand, whatever. So if you don't have a proper clinical examination, everything is, the rest that follows is all, sorry to say so, bullshit. But you need to have a proper clinical exam.
I perfectly agree. So the thing the concept that we have to try to hand over to you is that, first of all, clinical examination, clinical diagnosis still remains the mainstay of the diagnostic assessment. And actually, I would even say that electrodiagnostic test and imaging should confirm what is your suspicion. So now we have one more comment from Dr. Khizer.
Can I just add on to something here?
Yeah.
So just elaborating and adding on to what you guys have just said. See, when you're considering imaging, there are a couple of other factors you have to consider, particularly in case of traumatic injuries and nerve cutting and transactions. Is in setting of trauma, imaging will be confounded with a lot of soft tissue changes which are already going to be present, and they may give you a false impression of the extent of the nerve as well as soft tissue injury. So you have to take all of that with a pinch of salt, and it comes back to the point that the clinical assessment is essential, and the communication between the radiologist and the clinician is essential to come to the right diagnosis. So I'm not in favor of labeling a diagnostic intervention as gold standard, because when you label that, that means you're putting too much pressure on that particular investigation to give you the final answer. And the final answer is usually based on 2 or 3 different things rather than one.
Yes, I agree on that as well. I think now it's time that we start with the quiz. So if Professor Raja can give us the questions, and this will be conducted by Dr. Fatma and Dr. Khizer.
So launch the quiz. Okay. All of you are requested to please take the quiz. You can see it on your screens, right?
Yeah.
Fine. You have 10 minutes.
Fatma, can you just read the questions and start with it?
Yes. And a lot of questions about having the slides. I'll send them to you, Deborah, and then you can give to the participant. Okay, so question number 1. A 25-year-old presents for, he woke up one morning with weakness in his left hand. He was partying at night and he fell asleep on the couch. And his arm was hanging over, or a park bench, okay, after drinking heavily. On examination, he has wrist drop, so wrist extension 0, finger extensions also weak, and some sensory loss over the dorsum of the hand. What is the most likely diagnosis? And there should be some multiple choice.
Has everybody?
Answers will be shared at the end of the quiz.
Okay. So do you think we can proceed to the second one?
Sure, sure.
Okay, so the second question, a 47-year-old woman, and she has some tingling in her hands for 3 weeks. She woke up with tingling at night, and she also noticed it when she's driving. When you examine her, she has reduced pinprick sensation and the palmar aspect of the first and through the third digit, and the lateral aspect of the fourth digit. So pretty classic. Strength is normal, Tenel and Fallon sign are absent or negative. What is the most likely diagnosis? We'll give you 1 minute. It's too easy. Okay, I can go ahead to the third question.
Yes, of course, please.
A 32-year-old woman, she had 2-day history of left leg weakness, and her foot is floppy. She can easily trip, and some numbness and tingling in the dorsum of the left foot, so foot drop. No associated back pain. Past history, she had gastric banding 4 months ago and lost for morbid obesity, and she's lost, I think, 10 kgs or a significant amount of weight. Examination 0 out of 5 for ankle dorsiflexion, ankle eversion, and left great toe dorsiflexion as well. Pinprick sensation is lost over the dorsum of the left foot. What is the most likely diagnosis? Should be easy, even though we didn't go through the entrapments and details. Okay. So that's it from myself.
Dr. Rana, can we have your questions?
Okay, yes. So the first question is regarding the imaging appearances of nerve sheath tumors. Which imaging feature would help differentiate a neurofibroma from a schwannoma on an MRI? Okay, the second question is pertaining appearances of median nerve and diagnosis of carpal tunnel syndrome. So on high resolution ultrasound, which measurement supports the diagnosis of carpal tunnel syndrome? Now, if you have somebody who does carpal tunnel syndrome ultrasounds for you guys over there, then you would have come across some nerve cross-sectional measurements. So this is a question regarding that. Which one do you think is abnormal? Okay, and the last one, which ultrasound finding during dynamic assessment suggest functional entrapment rather than fixed compression of the ulna.
We have 4 more minutes to end the quiz. All the participants are requested to please attempt the quiz. Only 40% of the participation is now complete. This is not a measure of knowledge, but this is the measure of how far we are able to convey our presentations. Please go ahead and attempt the answers. I would like to mention to all our participants that there have been several questions about sharing the screenshot, which is not necessary. The Zoom does generate the attendance, even in minutes and seconds, how much time each of you has spent. So that is not a problem. And regarding the sharing of slides, this webinar will be archived on the ACNS YouTube channel. I will show you at the end of the quiz how to get there. We also have archived the part 1 and part 2 on the same channel. We have just 2 minutes left. I will request all the participants who have not participated to please answer the quiz.
How many participants haven't done the quiz yet?
62 of 84, that is 73%. 74 numbers are rising. We have just 1 more minute. There are 16 people who have not yet answered.
Mm-hmm.
Okay, 78%. Numbers are rising. Okay, it's 10 minutes and 69 out of 84 people have answered the quiz. So we'll end it now. Okay, Deborah. So I will end the.
And did you want to show the results of
Yes, of course.
Yeah, thank you so much.
Okay, so I'll share the results now. Okay, so for the first question, 78% have answered it correctly. Radial nerve compression at the spiral groove.
Excellent.
For the second question, again 76% have answered it correctly.
Very good.
For the third question, again 76% have answered it correctly.
Perfect.
For the fourth question, 72% have answered it correctly. For the fifth question, 54% have answered it correctly. It was more of a hardcore radiology question which says median or cross-sectional area more than 10 mm square at the pisiform level. It will be a support measurement supporting the diagnosis of carpal tunnel. And the last
yes, can I just give a quick comment regarding that?
Yeah, sure.
So the reason I put this in is because that's the general cutoff point we utilized is the 10 millimeter square. So it's an easy number to remember. So if the report mentions close to 10 millimeter square, then you're thinking it's abnormal. Above 10 millimeter square is definitely abnormal.
Okay, and the last question, 68% have answered it correctly. Intermittent nerve flattening and loss of fascicular patinolia during flexion. So that's it. Thank you very much. So I'll just let you know how to search for these webinars. I will share a video. I hope you all can see. Okay. Okay,
Great.
so over to you, Debora.
Okay. I think we can wrap it up. I think it was another excellent session, I have to say. I have to share my gratitude for the organizers. As I said, Professor Yoko Kato, Professor Raja, Professor Boone. I have to say thank you to my chairs. And of course, the main thanks today goes to the speakers and to their incredible job. And then again, personally, I really have to thank them because they support my work on a daily routine. I think we might just remind that we are going to have the next webinar on the 24th of November. So there are a few more weeks. And of course, we will share the content and give the announcement as soon as possible. Okay, so thanks everyone. And I'll see some of you face to face and some of you in online in a few weeks. Thanks again, everyone.
Thank you. Bye-bye.
Appreciate it.
See you.
Take care.